All right, shoulder anatomy. Let's talk about shoulders. Shoulder complaints are pretty common. They're often in fast tracks and things like that. The shoulder is a joint that gives people a lot of issues. Obviously, they do lots of things occupationally that involve their hands, so that all goes upstream. The shoulder is not a particularly, there are a couple of joints that aren't particularly well designed. So the knee, for example, is a fabulous joint if you walk on all fours like a dog. You don't hear about dogs having ACL tears. The knee is a great joint if you're on all fours. It's pretty stable, it works out just fine. As soon as you have to walk on your hind legs, the knee, not so smart. Similarly, the shoulder is a joint which doesn't have a lot of bony stability to it. It's a joint with a tremendous range of motion. It's a joint that dislocates easily. It's a joint which has a lot of soft tissue issues around it regarding things like tendonitis, bursitis, arthritis. And so from those standpoints, it's a joint that's a little bit problematic and produces a lot of visits. This is sort of your standard picture, which shows in no great detail a bunch of things about the shoulder, but one of the key things to note here is there's nothing really bony holding it in place. A lot of soft tissue components are important here. And here you see the coracoid process and the clavicle. You want to make sure it's not a clavicle fracture causing shoulder pain. You see the AC joint. You see the bursa, and this just shows one bursa, as did the last picture, but there are often multiple bursa around the joint, and there's bursa under the deltoid as well. And then you see part of the rotator cuff reaching over the supraspinatus tendon, which is one of the major components, inserting on the greater tuberosity. You see the long head of the biceps and the humeral head that's sort of balancing, if you will, in the glenoid fossa. And the labrum are the edges of the glenoid fossa, which kind of deepen the cup for it to sit in. But it's really just perched there, held by the rotator cuff predominantly. So bursa important, low bony stability, combination injury patterns. If you have a rotator cuff, you might have another injury as well. If you have a dislocation, it's almost certain you have some component of rotator cuff. You could have a dislocation with a fracture. These are these combination patterns. Functions highly dependent on the soft tissues, and lots of soft tissue problems will produce chronic shoulder pain. So inspection, palpation, range of motion is important to talk about, strength testing and sensory testing. There's a good video here which you can look at, but the shoulder exam is actually fairly difficult to do if you want to comprehensively look at someone's range of motion and really assess the whole thing. And even just palpating the shoulder for crepitance or for clicking or partial subluxation is fairly useful to do. All right, so let's get into some of the specific sort of common garden variety stuff. AC separation, really common with a fall. This is when someone, they wanted to have a foosh, they wanted to break their wrist, but the fall happened so quickly that they didn't get their hand out, so they landed on their shoulder. Happens when you fall off a bicycle, happens when you tip over and you're holding on to something, and so you land right on your shoulder and you spring your AC joint. There's 3 grades of this, grade 1, 2, and 3, so even if it's not visibly sprung, there's no notch there on exam when you compare shoulder to shoulder. If it's tender to palpation, it's still a grade 1, if they're point tender at that point. We used to do weighted views to see if we could separate it and demonstrate the difference between a grade 2 and a grade 3. Those have largely gone by the board because we've realized that when you load someone up with weights in their arm, 1, it really hurts if they have an AC separation, and 2, they recruit other muscles to hold it in, so it doesn't actually demonstrate the pathology you were hoping it would. And simple management for an AC separation is usually just a sling, but I'll tell you, even when I look at people applying slings in my practice with residents and other advanced care practitioners, I see that a lot of times they put a sling on and it's just sort of bearing the weight of the forearm. So if it's holding the weight of the forearm, that's great if what they've got is a wrist injury or something like that, but if you want to help an AC separation, it needs to bear weight at the elbow. So the sling actually has to be pulled up quite a bit. And the same, by the way, if you're going to put a sling on a clavicle fracture, you need to hold the weight at the elbow. Just letting it slink in there will give some benefit, but you'd really like to snug the sling so it starts pulling up on the elbow, and so you're unloading the shoulder girdle. And that's what will give you pain relief if they have an AC separation and allow appropriate healing. And that's what will give you pain relief if they have a clavicle fracture. So here we see a bunch of things where they're showing the different grades and which ligaments are torn. Obviously, when you get down to the bottom one, a grade 3, not only is the AC joint disrupted, but the corticoclavicular joints are all out and the acromioclavicular ligaments are all out. And you can see that it visibly springs up, giving you a pretty prominent lump in the shoulder. Compare the lump in grade 3 versus the normal. And notice in grade 1, it pretty much looks normal, but it's point tender. Grade 2, you start seeing a little lump. Grade 3, it's fully sprung. All right, another really, really common complaint, particularly common with people who are using their upper extremities dynamically at work, is shoulder impingement syndrome. It is partly the nature of their work that causes it, but it's also partly the nature of their anatomy. If they have a tight shoulder, you can have a tight shoulder the same way you can have a narrow pelvic girdle. Ask women about the differences between having a baby with a narrow pelvic outlet and a bigger one, right? There's anatomic variation here. And similarly with the shoulder, if your acromial process loops around in a tight hairpin turn, if there's not much room under your AC joint, then you're much more at risk for developing an impingement syndrome. So it's partly the work, it's partly the native anatomy of your shoulder. Add to that a third thing, which is it's partly if you have some inflammatory process, which is gumming that up, whether it's a post-traumatic arthritis, whether it's an adhesive capsulitis because you've injured your shoulder or dislocated it, then you start getting into this. The key issue here is that with impingement syndrome, passive range of motion will cause it to impinge. So even when you passively lift their arm up, they get pain in their shoulder because of the mechanical impingement that's occurring. They may have pain on abduction of their arm and on any particular range of motion, but distinguish this from a rotator cuff where in particular it's active abduction and external rotation that hurts. It's the employment of muscles in the rotator cuff, the active stuff that hurts, as opposed to here, passive hurts as well. The treatments for this are stretching exercises, rest, massage, NSAIDs. The patients are often really frustrated with this. Now, if they have prominent components of bursitis or tendonitis, I'm not crazy about it. I inject everything doc. You'll meet docs who will inject anything. You know, they got an itchy eyebrow, I inject those. I don't, you know, I'm not one of those. But the shoulder is really a pretty injectable, accessible joint where mixing a little steroids with a little bupivacaine will produce a lot of relief for them in the short haul. It also, again, identifies for them that you've found the problem, so it adds a lot of confidence in your diagnosis. And a long head of the biceps, I'm happy to inject around that. A subacromial bursitis, subdeltoid bursitis, I am happy to inject those. Whenever you talk about this, people say, well, what's the recipe? There are dozens of recipes. Doesn't matter which steroid, no. Doesn't matter how much bupivacaine, no. My answer is some. So when they bring me the steroid, it comes in 4 or 8 milligrams. That sounds like some. I'll take all of it, whatever they give me. 4, 8, I don't care. 4 if 4 is what they got, I take 4. And then I'll mix in some bupivacaine, 0.5%. I like the 0.5% for this. And I'll drop 4 or 5 cc. Sometimes the solution gets cloudy and someone goes, oh God, like there's some magnificent alchemy happening that's made this impossible. No, just go ahead and inject the cloudy stuff. It doesn't matter, it works fine. What does the literature say about the topic? A lot of people are shy about injecting because they think, I don't know the anatomy, I don't know exactly where I am, I don't want to have a problem. Well, first off, over the dome of the shoulder where my hand is, there's no vital structures. There's no nerve you can hit, there's no artery you can hit, and all of the literature says that this is just like horseshoes and hand grenade. Somewhere nearby is good enough. In fact, there are some papers that say that if you were to inject it into their buttocks, that that's close enough, that they'll get substantial relief from that. So I like just sort of going in the area where they have maximal pain and tenderness. Obviously, use a small syringe, a small needle rather. You'd like to, you know, not so small that it's crinkling over, but a 27 works great. And then I sort of go into their areas of maximum tenderness. Don't inject if you're hitting resistance. You don't want to inject this directly into a tendon sheath. You know, 4 milligrams of Decadron into a tendon sheath may expose them to a risk of rupture. So if you're hitting resistance, stop, but just move around and get it into the areas where you're not hitting resistance. It's fine, and you'll have lots of benefit with that. So here we see some look at shoulder impingement, and just sort of showing here you see the subacromial bursa getting scrunched because the acromial process is tight, and you may see that as well. You can also see it tight around the coracoid process. The coracoid process can be tight too. All right, calcific tendonitis. Sometimes you'll see it. This x-ray that's shown here with the beautiful calcified tendon is a fairly uncommon one. A lot of times if you'd like to see, for example, one of the more common ones to calcify is the long head of the biceps, but you won't see those calcifications unless you specifically ask for internal and external rotation views of the shoulder. And I don't know if it's that important for you to find it. If the biceps is tender, the biceps tendon is tender, then go ahead and inject around it. You get a painful arc syndrome. This is sort of a calcified bursa. This one person might have fallen on it and hemorrhaged into their bursa. It also, it seems a little bit more in the deltoid region there in this one. All of that is fine. It's nice when you see it because you should always show the patient this when you find it. If you don't find it, tell them they have it anyway. But if you see it, show it to them because they always look at it. I love showing people stuff on the x-ray. They come up to the PAX machine. They go, oh, yeah. I love showing them fractures especially. They go, is it compound? They love the word compound. Is it broken or is it just fractured? You get those kinds of questions. I love it. And then the next thing that always happens, like when you show them that, the next thing that happens is they always hit the person who came with them, their significant other or their family. I told you it was broken. Which reminds you of another thing, which is that a lot of people who come to the emergency room are partially there for validation, right? Their family members, their spouse, the people around them have told them they're a pussy. Don't be such a wimp. You're always bitching, whining, complaining, moaning. Now I'm here waiting for 6 hours in the emergency room with you. Come on, toughen up. You know, there's all these phrases. And so when you have something to show them, you should always show them so they can go, I told you, because they're there for that. That's like a very important therapeutic moment. All right, biceps tendon rupture can happen on the proximal side or the distal side. This is what you're seeing here. The proximal head rupture gives you the Popeye arm. You can diagnose this with ultrasound. I don't think I really need an ultrasound to know that that's not the normal anatomy of that guy's arm, unless he happens to arrive to the emergency room with olive oil. I'm pretty confident that there's a problem there. And they'll often tell you they were doing an activity and they heard an audible snap and then their arm looked like this. But when they're partial, ultrasound can help you. And so these are something that you'll encounter. You should ask about recent fluoroquinolone risk usage. We've talked about this. Now, let's just say you took, Levaquin for a week for some respiratory infection. How long are you at risk for a tendon rupture? Is it just while you're taking it? No. You have substantial, like 3 times the risk of a tendon rupture for the next 3 months, like twice the risk of a tendon rupture for the next 6 months, and an ongoing risk that's measurable out a year. So it's not just while you're taking it. All right, we've already talked a little bit about thoracic outlet syndrome in the last talk. We talked about the elevated arm stress test, the EAST. We talked about the Adson test. And this is sort of a review, so I'm going to move. Here you go again, the Adsons and the EAST. We've talked about these, so I'm going to dispense with those. Clavicle fractures. Middle third is the most common. The clavicle is the most frequently fractured bone, period. And part of the reason is because you have an opportunity to fracture it day one. And by that I mean clavicle fractures happen at birth. Like it's some sort of cruel trick. Like why in God's green earth does a baby need a shoulder girdle? Isn't it bad enough that the kid's head is mammoth and is trying to get out your birth canal? What, the kid needs a shoulder girdle too? It's kind of, I know this is teleologic reasoning, but humor me. The reason kids have clavicles is because they're actually making red blood cells in those. So the clavicle in a newborn is actually an important hematopoietic organ, as is their sternum. Later in life, your clavicle and sternum don't make that many red cells, but when a kid's about to challenge a new world with oxygen in it, if you want to know where those red blood cells are made, they're made in their clavicle, their sternum, and their liver. And so the hematopoietic organs are different at birth than they are later. And that's why kids have a clavicle to break. Now, when you see severely tented skin, you might want to reduce that a little bit so that that skin doesn't necrose and die. I think also that it's underappreciated, in particular for women, how important the clavicle is in terms of cosmesis with its healing. You know, a young woman who might want to wear a strapless dress would not like to have a huge galunk there, you know, something that looks like they're, you know, some battle survivor. So it would be nice if those didn't heal, so you should pay attention to that. Having noted all that, an appropriately applied sling is still the best treatment for it. Many orthopods will still, who are keeping up, will still tell those patients, what's wrong with those ER people? Don't they know you need to be in the figure of 8? So you have to prep the patient for that. The figure of 8 does not improve reduction. It actually increases non-union. It increases axillary pain. It increases axillary vein thrombosis. It increases axillary erosion of the skin. There's nothing good that comes from a figure of 8. So you have to prep that. I always like to tell them the literature says no, because I know that they're going to say to the orthopod, when the orthopod suggests they put one on, they're going to say to them, well, doctor, what about the literature? And nothing, that's, you know, doing that to an orthopod is kind of a cruel and unusual trick. So it's a little bit like when you hide the dog biscuit from your dog and it goes like this. You know, anyway, it's just my own, you know, I just humor myself with some of those things. Anyway, so no figure of 8 anymore. You can do ice. A sling is just fine. Apply the sling so it bears the weight of the elbow as shown. All right, rotator cuff syndrome. Almost everyone who has a dislocated shoulder at some point in their life probably has some degree of a rotator cuff injury. Some dislocations have more rotator cuff injury than others. For example, luxatio erecta, which is the anterior dislocation with your arm out like this, almost completely destroys the rotator cuff. And so if you saw one of those, they need to be followed up for it. But having noted that, simple falls can do it. Other repetitive activities can hurt it. Sports activities can do it. The rotator cuff consists of the sits muscles, SIT, the first SIT part, insert on the greater tuberosity, and the last S, the subscapularis, on the lesser tuberosity. And it is these muscles that are primarily responsible for joint stability. They hold the head of the humerus in that shallow glenoid fossa. There are lots of causes of pain here: tendonitis, tears, prior injury. What you're looking for is pain with active rotation. External rotation and abduction. Those are the two key motions. And external rotation in particular. So if you put your hand here and tell them to push out against it, they'll be wincing if it's a rotator cuff. And here you see the vector diagram. I like that image on the lower right. Not that we're trying to turn you into vector physicists at this moment, but it just shows you just how shallow the glenoid cup is and what the rotator cuff does to pin the shoulder in the joint. And here you see the 4 little colored, you know, lines with the little dot on the end showing the 4 muscles coming around to hold that shoulder in place. And the rotator cuff is weakest when you're in the quarterback position. So when your arm is up over your head with a leading elbow, like this, that means that your rotator cuff has exposed its weakness anterior, and a blow in that position will dislocate your shoulder quickly. And so that's one of the flaws of the rotator cuff. It's just how it was designed. And so certain activities will do this. So obviously a fall on an outstretched hand can do it because you're in that position. Kayaking is notorious. If you do a wave brace with a kayak, you're in a kayak and a wave comes, you reach up with the paddle to hold it. Now your arm's in the perfect position. You've added an additional lever arm, which is the paddle, and the weight of a wave. That will dislocate your shoulder in about 2 seconds. That's why the Eskimos have their own technique for relocating shoulders, the Eskimo technique. Because basically they say, I'm not paddling you home. You're either going to freeze out here or paddle yourself home. All right, shoulder dislocations, anterior, the most common, 95%, with a squared off shoulder as shown. Posterior are rare. You should find out why they have it. Seizures, electrical shock, direct blow. And then luxatio erecta, which sounds like something you get when you take too much Viagra, but is not that, is a rare with the extremity held up. It's the forearm to forehead dislocation. If they come in with their forearm to their forehead and they can't move it from there, that's luxatio erecta. As I indicated earlier, the primary importance here is that means they have a big rotator cuff tear. Always check the distal neurovascular status and relocate them. This often requires pain control, but the more you know about doing shoulders and the more elegant you are and the sooner you get to them, the more you don't need pain meds to do them. So I used to not be so good at doing scapular rotation, but with scapular rotation, I'm successful about 50% of the time with no meds. Hennepin to a milch, I can do another 20% of them without pain meds. And then there are some where there's just no way about it. The patient's too tense, they won't cooperate, I can't talk them down. You all know what that's like. Some patients you can talk to and say, breathe with me, work with me, I'm gonna go slow, I'll stop. Some patients you can have that conversation, you can get into the zone and do it. Some people you just can't. And so at that point then you should just KTMFO. You can figure that out. All right, so, but there are lots of techniques. There's 20 plus techniques to relocate shoulders, and you should know a few of them, not 20 of them. And you should not be using the high force techniques. So the Coker maneuver, this thing where you jerk it into internal rotation, that's a good way to break a humerus. So that method is dead. And the other method, which is the foot in the armpit pulling, that method is dead. Those are high force techniques, but any of the other 20 are fine. I don't think you need pre-reduction films on a young, healthy patient who comes in saying, my shoulder's dislocated. You've all seen them. They come, my shoulder's dislocated. They know what the diagnosis is. Why do you not know what the diagnosis is? So when they know what it is and it's all fits, then I don't think you need it. Now, if you're talking about an older person where you're considering a proximal humerus fracture and you don't want to pull on something that's fractured, by all means, get an x-ray first. But if it's obvious, all that's happening when you obtain pre-reduction films are, one, you're increasing your medical legal risk. I'll explain that in a second. And two, you're increasing the time that they have to develop spasm while you're getting them to the x-ray and back. And the way you're increasing your medical legal risk is if you relocate a shoulder with no pre-reduction films and afterwards the shoulder's in and they have a greater tuberosity fracture, well, then they had a greater tuberosity fracture when you started. It was there before. It's still there now. No big deal. But if you obtained a pre-reduction film and they didn't have a greater tuberosity fracture and you relocated it and now they do, all the pre-reduction film has done is serve to prove you broke it. It increases your risk, not decreases your risk. Now, who needs pre-reduction films? Like I say, if you think it's fractured, if there's something atypical about it, it's not obvious, then by all means x-ray it. But I think you can go ahead. There are a couple of papers now in the peer-reviewed literature saying you can move directly to reduction. By the way, people who have dislocated their shoulders multiple times, they know how to relocate them themselves half the time. Do you think they waited for x-rays? No, they do them themselves. You know, they go right ahead and do it if they can. Now, post-reduction films, there are some papers saying you don't need those either. I actually like them to prove it's in because some shoulders slip back out. I'd like to prove that it's in when I'm done. That's my own personal preference on it. Here's a list of many of the techniques, and the ones that have kind of gotten the most attention recently, I'm really a big fan of scapular rotation, but I would acknowledge that the first few times I tried it, it did not seem like it was working. It's a little bit, takes a little bit of time to get the knack of it, but once you have the knack of it, it really works just fine. Hennepin to the milch, those two in combination I like a lot. The milch is the pick an apple, right? So if you start the hennepin, which is external rotation and abduction, and a lot of times you kind of get up to here and it won't go. You're like, oh, I'm being patient. I'm letting them relax. It won't go. At that point, you should go up to over the head of the bed like this with the hand like I'm doing, like you're trying to pick an apple over your head, and that's the milch. So the hennepin quite naturally leads to the milch. You have to think about this before you start, though, because otherwise you don't have room at the head of the bed to step around them. So you actually have to move the bed away from the wall before you start so that if your hennepin locks up here, that you have room to go over the top to the milch. There's the Stimson. I love this when I'm busy. I got lots of patients to see. I'll give them 5 milligrams of Versed IM, hang the weights, and leave. Half the time when I come back, it's already in. If it's not in, a little scapular rotation will almost always do it. And so I like this when I'm busy. If I got lots of other patients to see, I can get this going. Here you see the Ferries, which stands for fast, reliable, and safe. This is basically you get them out to the hennepin position, external rotation abduction, and then you do the waggle. You get them out there and you do the waggle and see if it'll go in straight out. And then there's the Spazo technique, which shows a little bit of the rotation action. And these are just little things you could do. Here's hennepin, and then you see the milch. Hennepin to the milch, nice combo. All right, Hippocratic, not good. Eskimo is another kind of older, higher force technique, and the Coker I don't think you should do. These are more likely to cause axillary nerve injuries. By the way, you should always be checking the axillary nerve as part of your neurovascular check. It's sensation over the silver dollar size piece there, which is kind of stupid to check for, right? It's not like people are particularly sensitive with this part of their body. It's not like the tip of their tongue. So I think it's much more relevant to check motor of it, which is just to ask them to lift their elbow while you palpate their deltoid. I think motor check of the axillary nerve makes a lot more sense than sensory check of the axillary nerve. All right, posterior shoulder dislocations. These are missable. As I indicated earlier, they happen with electric shocks and seizures and things like that. Every couple of years, we M&M a resident at our place, and the story always goes like this. A patient's brought in with status epilepticus. They give him a drug, it doesn't stop. They give him another drug, it doesn't stop. They give him another drug, it doesn't stop. He gets rapid sequence intubated, etc. We get the seizures under control. He goes to the neuro ICU. On day 4, they extubate him, and they, at that point, as soon as they extubate him, as soon as they lubricate the guy's mouth, he goes, my shoulders hurt. And then they realize that both shoulders are dislocated posteriorly because the person had seizures, they were pulled out posteriorly. And so then a neurologist comes down to the emergency room, long coat, you know, the reflex hammer, ice cube melting in the pocket, a little vanilla oil. They come down and they say, you know, something to you in the emergency room like, did you look at the post-intubation film? And you get defensive and go, yeah, we looked at it. The tube was in. Yes, indeed, they say the tube was in. What about the shoulders? Did you notice those? Well, they were present. And they say, yes, indeed they were. And they looked like this x-ray, which is that they didn't look that dislocated. They looked perched, and they were both perched. They were both dislocated. So it wasn't even like one shoulder seemed different from the other. They were both out. And this is the classic internally rotated, posteriorly dislocated shoulder view, where it's called, it looks like a light bulb or a gun barrel or a drumstick. Anything that's been named that many times, it's been named because a lot of people screwed it up. And there it is. That's a posterior shoulder dislocation that doesn't look that dislocated. And here's the luxatio erecta with the forearm to forehead. These you can reduce. These are tougher to reduce, but they usually will go with inline traction in the direction the elbow is pointing. With sedation. You'll need procedural sedation on these. All right, after someone dislocates a shoulder, they bleed into their joint, and that blood has nowhere to go, and all it can really do is get ground down into the capsule and get all fibrous and heal up and turn into a fibrin mess, and that's called adhesive capsulitis. And if you don't keep that shoulder moving, then they'll end up with a frozen shoulder, which is why anytime you immobilize someone with a sling or in a mobilizer, you should tell them daily to lean against the wall and get their arm out away from their body and do these rotation things, which are called Codman's exercises. I routinely print Codman's exercises with the picture down and give them to the patients and warn them about a frozen shoulder. And here they are showing you the Codman's exercises. And you could download these. Proximal humerus fractures are actually fairly complicated. There's all these theories, like the 5-part theory, which is actually the best of the theories out there that talk about these parts. One part's the greater tuberosity, one part's the lesser tuberosity, one part's the shaft, and one part's the head where it goes in the joint, and there you see them. And so you can have multi-part fractures, and sometimes it's even appropriate for an orthopod to say, will you CT that so I can find out what's going on? And that's totally appropriate when they have a complicated one. And, you know, obviously if they're dislocated with a proximal humerus fracture, there's no point in pulling on that arm. you can't relocate them. So the complicated fracture dislocation, that's going to need orthopedic consultation and admission to be dealt with. You can put them, immobilize them if they're not dislocated in a sling and refer, but these are complicated injuries which you ought to certainly discuss with an orthopod when you're dispositioning them. All right, midshaft humeral fracture. These are really common fractures. One of the things you want to be aware of is in the middle of the humerus is the spiral groove where the radial nerve lives. And so when you have a midshaft humeral fracture, it's quite possible to have a wrist drop due to a radial nerve injury. So any humeral fracture along the middle third, you ought to be looking for a radial nerve injury carefully and making sure they don't have that. When they don't have that, oddly enough, these displaced fractures do pretty well with a sling, and sometimes they need a coaptation splint. But it's always shocking to me. They look like they should be, you know, that someone ought to drive some screws into them or plate them or something. And remarkably, they heal without that. So midshaft humerus fractures are one of the miracles of bone healing to me. And there you go. Thank you very much. And Diane is up next.